Good morning. Today is the third day from our conference, and we will talk about pediatrics congenital anomaly. And as we know that congenital heart disease, it's the most common congenital baby can born with. It's more than about 21% of congenital anomalies is cardiac. It's more than CP, Down syndrome, or baby who were born with other congenital anomalies. So first our speakers is Dr. Ismail Rida. Dr. Ismail Rida is graduated from Kuwait University, and he did his fellowship in Jackson Memorial Pediatrics Cardiology. Please join me and welcome Dr. Ismail Rida. He will talk about first lecture. He will talk anesthesia, disease in non-cardiac surgery, preoperative assessment, and optimization.
Good morning, everybody. Assalamu alaikum. First of all, I'd like to thank Dr. Huda Al-Foderi for actually inviting me here, as well as of the entire organizing committee for such a lovely conference to be held here in Kuwait, and welcoming everybody from coming across the world overseas to be in Kuwait, enjoying the nice weather, which is chilly today. To start with, like I spoke to Dr. Huda, having a 20 minutes or a 15 minutes talk through such a topic per se, which needs sometimes to have books to be written about. So what I will do, I might be actually touching turfs on other people's ground, so I do apologize for that, but more or less I'll make it like a roller coaster ride to just get it over with in 15 minutes. That's why the colors are confusing, actually, the yellow, the blue, the red, and etc. So hopefully today, both with me and Dr. Maria, be able to discuss the principles underlying the management of children with congenital heart disease who present to their local hospitals for non-cardiac surgery in particular. And again, we emphasize for the local district hospital. Describe at a glance the physiology of normal and pathophysiology of some abnormal circulation. Suggest a classification of low to high risk children. Discuss some preoperative assessment, anesthetic management, and postoperative care of these children in the local hospital setting. As Dr. Hani was saying, congenital heart disease is the most common birth defect. Approximately in the literature, 1 in 125 live births are affected. In Kuwait per se, I think that goes up to 3 in 100 or 2 in 100. But again, there is no evidence based on that, based on studies. Due to advances in medical care, excuse me, majority of these patients, unlike 40 or 50 years ago, are surviving through adulthood. And thus, they are going through all life incidences, whatever they are going through, other, the general population, our patients with congenital heart disease as well, they are going through. So they are having emergency situation as well as elective surgeries. And in general, these patients have an increased risk of morbidity, perioperative cardiac arrest, and a higher 30-day mortality, for which we are going to discuss their cases in these few lectures. And the complexity of the cardiac defects and the variety of the non-cardiac surgery makes it impossible to generalize an approach to all of them, a one approach type of thing. For example, a 9-year-old child with a repaired ASD who requires an emergency appendectomy, simply appendectomy, presents minimal risk, yet a 12-year-old with a failing single ventricle circulation, having a Fontan, going for the same operation, has differently and totally risk factors involved in his case and his management. Some limitations to remember when it comes to pediatric age groups. The evidence for classifying children with congenital heart disease who require non-cardiac surgery as high, intermediate, and low risk is very limited. Few studies exist evaluating anesthetic techniques in children with heart disease for non-cardiac surgery. Studies for complication in a rapidly changing field, such as cardiac surgery, and their advances may reflect an outdated treatment strategies. So an ongoing, advances are going on in the pediatric cardiac surgeries, so therefore things are changing. The complications are changing. This review is intended for the District General Hospital again, and how they're going to manage these patients who are undergoing non-cardiac surgery. So to remember, the variety and complexity of our congenital heart disease makes a one-size-fits-all approach, like I said, will be impossible. I would just present few cases now just to remember, which we'll go through at the end of the lecture. A 6-month-old male with an unrepaired large VSD presenting for emergency surgery for a scortal swelling. Second, a 6-year-old with a repaired tetralogy of Fallot presenting for dental extraction due to dental caries. Third, an 8-year-old with a Fontan circulation presenting for emergency surgery for reduction and fixation of a supracondylar fracture with neurovascular compromise, so he might lose his limb. So remember those 3 scenarios which we'll address at the end. Physiology of different types of circulation. And again, different books, different references, have different description of what I'm going to say. So there might be the nomenclatures not applicable to what we think for the congenital heart disease. So first we have the normal or serious circulation. The normal circulation, as it says, is separate systemic and pulmonary circulation working together in series. Applies to most types of repaired congenital heart disease. Some forms of unrepaired congenital heart disease also have a normal circulation, but with 1 or more defects where mixing of blood can occur, like an ASD or VSD, which are the most common. Left to right shunt result in increased pulmonary blood flow and potentially decreased systemic blood flow. Right to left shunt causes deoxygenated blood simply to flow into the systemic circulation, causing cyanosis and reduced pulmonary blood flow. Amount of shunting depends on the size of the defect and the pressure gradient, which is usually judged by the systemic and pulmonary vascular resistant. Changes in SVR and PVR as a result of anesthesia, including the administration of oxygen, simply have greatest effect on large unrestricted defects. Infants with a large unrestricted defect, such as a VSD, may exhibit balanced circulation physiology, as I'm going to describe in the following slide. So this is just a description of simply to remember simple holes like an ASD or a VSD. What happens when you are giving oxygen? What happens during ventilation, during anesthesia? And TOF, where you have a right-sided obstruction as well a defect which is mixing between both ventricles. So if we drop the SVR, systemic vascular resistance, for whatever agents we are using, we are going to have more of right to left shunt. And if we drop the pulmonary resistant, then we're having more left to right shunt. And accordingly, whatever happens to the patient. Balanced circulation or parallel circulation, the pulmonary and systemic circulation communicate with each other and function physiologically as being in parallel. The anatomical abnormalities causes the blood flow to the systemic and pulmonary circulation to vary depending on the relative resistance in each circuit. Thus, blood flow to the lungs and body is balanced between SVR and PVR, hence the term balanced. So depending on the resistance on each side, more flow will be to that lower side of resistance. Excessive pulmonary blood flow causes pulmonary edema and poor systemic perfusion, and insufficient pulmonary blood flow causes profound cyanosis. For example, for balanced circulation physiology, infants with a large unrepaired AVSD, AV canal, these infants have predominantly left to right shunt flow. High concentration of oxygen during anesthesia will increase pulmonary blood flow and reduce systemic perfusion. Conversely, large doses of induction agent may reduce systemic vascular resistance so much that shunt flow is reversed, causing desaturation and cyanosis. The excessive pulmonary blood flow also makes the child vulnerable to development of pulmonary hypertension by increasing PVR. Single ventricle circulation. The single ventricle pumps oxygenated blood around the body. So that single ventricle, whether being the left or the right ventricle, while blood flow passively to the lungs down a pressure gradient from the pulmonary artery to the left atrium, the wedge, what we know as the wedge pressure. So initially these patients, a lot of them undergo a BT shunt, but not necessarily all of them, but all undergo a Glenn anastomosis, which is between the superior vena cava and the ipsilateral pulmonary artery, usually the right, at 3 to 5 months of age. And usually these patients' saturation ranges between 75 and 85%. So knowing that is important. And their final stage of repair is usually ending up by the TCPC or the Fontan circulation, where IVC is connected to the ipsilateral pulmonary artery, which is usually the right pulmonary artery. And by that, they will have a normal full saturation, unless there is a problem and there is a fenestration. The pressure gradient from the pulmonary artery to the left atrium is now the sole determinant of pulmonary blood flow. Therefore, increases in pulmonary vascular resistance and intrathoracic pressure can compromise pulmonary blood flow. And this is important for the anesthetist to know. So they are on a passive circulation phenomena. Spontaneous breathing causes negative intrathoracic pressure and augments pulmonary blood flow. So always is ideal. Positive pressure ventilation may allow greater control of oxygenation and minute ventilation, thus avoiding hypoxia and hypercarbia. Positive and expiratory pressure should be optimized as well, and peak inspiratory pressure and expiratory times minimized to facilitate pulmonary blood flow. And in general, avoid high peeps when patients are on ventilator and patients with single ventricle physiology who have Glenn or Fontan. Because high peep, as everybody knows, will increase your pulmonary vascular resistance and therefore compromise that flow, that passive flow. This is an important, actually, table for risk classification of children with heart disease undergoing non-cardiac surgery. I'm showing it now, and then it's important to know that it is based on different itineraries for risk classification for patients. So we have the low risk, intermediate, and high. And all it depends on the physiological status of the patient, whether he has some complication, including cardiac failure and pulmonary hypertension, complexity of the lesion, that's the cardiac lesion, the type of surgery, major or minor surgery, and whether it's emergent or elective surgery, age of the patient, preoperative hospital stay, as well as the American Society of Anesthesia physical status of the patient, which ranges from 1 being having the organ, no organ being affected, till 6, which is basically a brain dead patient. So we'll not be dealing till 6, I think. We'll go up to 5. So first, in that risk classification, the physiological status risks. Cardiac failure. Cardiac failure can be due to a volume overloaded heart or a pressure overloaded heart, or in some situation, both. Volume overload may result from residual shunts or incompetent valves, as is common after TOF repair, for example, or AV canal repair, where you have AV valve regurgitation being significant, and pressure overload from residual outflow tract obstruction. Children with severe cardiac failure must be identified because they are at very high risk. And a recent study had shown that 10% of suffer cardiac arrest and 6% required perioperative inotropic support. These children should be transferred to a specialist center even for minor procedures, these high-risk patients. In the emergency situation, children may need retrieval by a specialist transport team. In the rare event of transfer being impossible, advice should be sought from a tertiary center, pediatric cardiologist, and pediatric cardiac anesthetist services. Children with milder degree of cardiac failure pose less risk. In the local hospital setting, either gaseous IV induction is possible, but induction times will be prolonged, so patience is needed to prevent excessive drug administration. Avoid prolonged use of sevoflurane, I'm now touching on other people's turf, like I said. Propofol may cause a profound decrease in cardiac output and is best avoided as an infusion drug, though it's one of my favorite. Ketamine is the IV agent of choice. Venous access, as simple as venous access,
5 minutes. 5 minutes.
May be difficult, so having a second experienced anesthetist is often helpful. We will be dealing with patients like this. It's important to know the determinant of cardiac output. Keep that in mind. As well, what are the factors which worsens your heart failure? One important thing that anesthetists, at many occasions, they ask us when patients are on heart failure medication whether to stop or not. There is a consensus that actually in pediatrics, unlike in adults, you don't need to stop any of the medication. In particular, the anesthetists are worried about the ACE inhibitors, so you continue. Pulmonary hypertension. I'm sure that everybody knows pulmonary hypertension. If a child receiving treatment for pulmonary hypertension, they should be transferred to a specialist center where full pediatric intensive care facilities are available. Arrhythmias. Most of our patients who have some sort of ventriculotomy, they have right bundle branch block, but that doesn't necessitate that they have complete heart block. So right bundle branch block is nothing to worry about. But having ventricular ectopies is an ominous sign. So when you have an ECG with ventricular ectopies on a patient, that is considered as a high risk. Children with ventricular ectopy on ECG or a single ventricle circulation should be referred for surgery in a specialized center. So your ectopies, and the second one is actually a complete heart block. Cyanosis, I will go. What is important regarding cyanosis is chronic cyanosis, which affects major organ systems. The main problem relating to anesthesia and surgery are polycythemia and coagulopathy, increasing risk of hyperviscosity causing cerebral vein and sinus thrombosis. Dehydration, fever, and iron deficiency anemia increases the risk. Preoperative IV fluid therapy may be used to minimize this risk. Very importantly, aspirin should not be stopped. This is a common, usually, again, in most of cases. Complexity of heart disease, single ventricles, balanced circulation, cardiomyopathy, severe left ventricular outflow tract obstruction in particular. Types of surgery, of course, between simple and major surgeries. We go back to the same slide that I introduced earlier, which actually stratifies patients according to the risk classification.
2 minutes.
I think I started a bit later. So key features and preoperative assessment. This slide is important to remember. Knowledge of the underlying lesion and type of circulation. Are changes in SVR, PVR likely to be of significant importance? Evidence of recent upper or lower respiratory tract infection is very important. Venous access, like we said. Routine drug therapy. So again, there is no need usually to stop anti-failure medication in particular. Aspirin should be continued in most of cases. Sedation as a premedication commonly is used to avoid distress, minimize oxygen consumption, and may also reduce the amount of induction agent, so minimizing reduction in SVR. Endocarditis prophylaxis to follow the national guideline. As for the SBE prophylaxis, all these councils on the slide, actually, they gathered together in 2007 and they revised the SBE prophylaxis recommendation. They concluded only an extremely small number of cases of infective endocarditis might be prevented by antibiotic prophylaxis for dental procedures, even if such prophylactic therapy were 100% effective. So only extremely small number. But still, we have to do it on the high-risk patients. Infective endocarditis prophylaxis for dental procedures is reasonable only for patients with underlying cardiac condition associated with the highest risk. Among those, prosthetic cardiac valve or prosthetic material used for cardiac valve repair, previous infective endocarditis, some congenital heart disease, including palliative shunts and conduits, complete repair congenital heart disease with prosthetic material or devices, only during the first 6 months after the procedure, or some other residual lesions which are adjacent to such synthetic materials. Cardiac transplantation recipients who develop cardiac valvulopathy. The last conclusion, administration of antibiotics solely to prevent endocarditis is not recommended for patients who undergo a genitourinary or gastrointestinal tract procedure, which is commonly endoscopies. This is antibiotic regimen. Surgery in anticoagulated patients, a question which usually arises, when it is safe to operate when long-term anticoagulation is involved. The answer, there are no precise consensus, but recommendations are there. Generally, dental extraction, minor biopsies, ophthalmic procedure, and diagnostic endoscopies are safe without altering anticoagulation regimen. Elective invasive surgeries with INR around, best to be around 1.5, and therefore stopping warfarin if the patient is on it at least 4 to longer days, depending on the INR status prior to surgery. Emergent surgeries, we can reverse the INR to normality with FFP, vitamin K, and prothrombin complex concentrate. For aspirin, American versus Europeans, I personally don't stop it like we said. Plavix, and some of the patients in pediatric use it in adults more, but we have some kids on it. We stop a week prior to surgery. And we can always achieve active anticoagulation or prophylactic anticoagulation with low molecular heparin or unfractionated heparin.
Finish this last.
So it's important to go actually to the, these things I think Dr. Maria are going to discuss, propofol, ketamine, and let's go through our examples that I started at the beginning.
Time is finished.
Okay, shall I? So these are just the last 3 slides. So the 6-month-old with an unrepaired large VSD presenting for emergency surgery for a scorta swelling. Physiology, compensated on examination, moderate cardiac failure, on diuretics, but feeding well and gaining weight. Lesion is simple, awaiting VSD repair next month. Risk category, intermediate, physiologically well compensated, simple lesion, minor surgery, but less than 2 years old. And it's an emergency surgery. Management depends on a local anesthetist and surgical expertise. If local hospital routinely performs surgery on children under 2 years, then safe to undertake locally. Otherwise, consider discussion with and transfer to a specialist center. Anesthesia consideration, slow gas or IV induction. Be aware of possibility of poor cardiac reserve. Avoid high inspired oxygen concentration in order to minimize left to right shunt and maximize systemic perfusion. May require higher ventilatory pressures than expected because of presence of pulmonary edema. Avoid air bubbles in venous lines because of the risk of paradoxical embolus. Endocarditis prophylaxis is unnecessary. The 6-year-old with a repaired tetralogy of Fallot for dental extraction due to dental caries. Physiology is compensated on examination, good exercise tolerance, no sign of right failure. ECG shows a right bundle branch block and no ventricular ectopies. Lesion is simple. Risk category is low. Management, perform procedure in local hospital. If ventricular ectopy is present on ECG, considered to be high risk and seek cardiology advice. May need to postpone surgery or transfer to a specialist center as high risk of life-threatening arrhythmia. Anesthesia consideration, gas or IV induction, no need to have endocarditis prophylaxis. The 8-year-old with a Fontan circulation presenting for emergency surgery for reduction and fixation of a supracondylar fracture with neurovascular compromise. So this is a major thing and carries a high risk. Just for the anesthesia considerations, gas or IV induction, consider spontaneous ventilation as this aids in pulmonary blood flow, but must avoid hypoxia, hypercarbia, and atelectasis, which increases our PVR and compromises pulmonary blood flow. Full stomach may require rapid sequence intubation and positive pressure ventilation. If using positive pressure ventilation, avoid high pressure, high PEEP, and long expiratory times. Slight head-up position simply can aid venous return and pulmonary blood flow, and so does the raising of the legs. Endocarditis prophylaxis is not used. So in general, I would say, for the anesthetist, it's good to know your patient, know your medications, what they do to this particular group of patients, do what what you can do best and what you know best, and never hesitate to ask for an advice. Thank you, and sorry for the rapid sequence of this lecture. Thank you.
Good morning, everybody. I'm very happy to be invited here in this great meeting and great location. Thank you so much for the committee. And I'm actually probably presenting pretty much the same that you were hearing already from the previous speaker. Maybe a little dense also. It's a huge topic that you can't really not present in a short time of this, but I'm gonna try. This is how I advance my slide. So this is where I work in Houston. It's the Texas Medical Center, all these buildings, several medical schools, several hospitals, and this is the Children's Hospital Memorial Hermann. I will discuss the pre-anesthesia evaluation from the anesthesia standpoint and discuss some anesthesia management for these children and the classification and outcomes also. And I have to speak fast. I try to go through all my slides in 40 minutes. It's difficult, but I will try. So this you heard already this morning. There will be more and more patients coming to the general hospitals because now the survival rate of the surgery and the treatment for congenital heart disease has improved so much over time. Here you see just a slide that shows you the distribution of the ages of patients who have cardiac surgery. And the survival rate, if you heard earlier, is over 90%, and the distribution of the lesions are about 55 for simple, 30 for moderate, and then 50 for complex lesions. And these patients will show up in your OR. Here are the most common lesions, VSD, coarctation, and this was mentioned before also. The classification, there are actually several classifications of congenital heart disease, and they overlap somehow. There's the shunt, the mixing lesions, the obstructive lesions, regurgitant lesions that are mostly more present in patients who have been corrected actually, and the single ventricle lesions. Just here, another classifications with the different types of lesions that go under these classifications, and they overlap, and as was said before, they are so complex, and each lesion actually has so many possible variations and also surgical approach in some regard that there's no way that you can just have, okay, for this you always do this way. It's really an individual approach to each child. And here comes the preoperative evaluation. You really cannot do this in 5 minutes. It's not like, you know, normal child comes, you see, hello, good morning, how are you? This is not. You have to sit down, you have to identify the lesion, you have to understand the lesion and see what previous corrections was there. See the imaging, and if you don't, as was said earlier already, take advice from somebody who knows it. Talk with the pediatric cardiologist who is following this child. Of course, it's all different if it is an emergency situation, but still, you know, sometimes a little half an hour to look into the details goes a long way. When you do physical examination, really focus on the cardiac signs and symptoms. Failure to thrive is very common in these children who have heart failure, how many cyanotic spells, arrhythmia, feeding problems, all these are delay in milestones, all these are signs that show you how sick your child is. And very often these lesions are also associated with malformation, as was mentioned earlier, Down syndrome or DiGeorge syndrome. They can have additional facial malformations, so the airway can be a problem. They also, because they have been maybe intubated for some time, they can have tracheal stenosis, so you want to look into this. Some lesions are also more prone to have respiratory infections combined, and again, the cardiac situation should be optimized, and you really you need the help of the cardiac the pediatric cardiologist. So here's just an idea when would you need a cardiac consultation. And in cyanotic patients, it should be really done within the last 6 months, even if they're well compensated, and of course, if not, they should be immediately preoperatively done. And for the acyanotic patients, same, well compensated or less compensated, the consultation should be pre-op immediately for the poorly compensated. You need to look at the hematocrit. Cyanotic patients specifically can have a very high hematocrit, and if you follow actually the increase over the hematocrit over time, it gives you an idea also, if you have access to these data, it gives you an idea if the hypoxemia is worsening or not. Coagulation was discussed earlier. Electrolytes, if they're on diuretics, you want to optimize all this before you go into anesthesia. Same thing here, we continue all medications pre-op. Just when the patient is of certain antiplatelet therapy and Coumadin, then there is a discussion. Can we stop it? What is the procedure? That's a discussion between the surgeon, the pediatric cardiologist, and the anesthesiologist. I think teamwork is here really key for have the best access. And if you are in a hospital that normally don't do this, just go on the phone and talk and make that communication happen. NPO time is crucial. You do not want dehydrated children. For some lesion, it's really very important. For BT shunts or fellow TOF patient, they really do not like to be dehydrated. So they should really be allowed to drink clears until 2 hours prior and then take their medication. And if possible, be the first case in the morning when everybody is alert and not tired. And also they should be awakened in the morning to drink and not say, oh, my child was asleep, it isn't. But actually parents who have children with these diseases, they're generally pretty well informed, and they understand that these things are important for their children. For the monitoring, normally standard ASA monitoring. Precordial stethoscope is used very rarely, I would say. We not always use a 5-lead EKG, but temperature probe is important. Non-invasive blood pressure, and then you have to think if there is any stenosis somewhere, where do you put your blood pressure to make sure if you have a coarctation, for example, the best blood pressure is on the right arm because that shows you the pressure, the central pressure. Same for saturation probes. You have to think where you put your saturation probes. It's in general good to have 2 different saturation probes. So if you have just a technical problem with one, and you have only one, it's not immediately a stressful situation. Is this now my child or is this a technical problem? So it's advised to do this. Capnometry should be also used. Let's say you just do a sedation for a colonoscopy or something, deep sedation. You still should use a capnometry for these children, even if they're not intubated. IV access also was mentioned before, can be very difficult because they had multiple IVs and central lines. And so in general, if you know you will get an IV, you can do an inhalational induction and get an IV afterwards. But if not, you may want to consider that you place an IV before under just a little bit of sedation for this child, or you have a PICC line placed or something, if you have time to do this. Arterial line also depends on how stable the child is and how invasive the procedure is. Also here you have to think about the location. You have to avoid A lines on the side of the shunts, and brachial arteries are generally avoided in children too. Central line also are most of the time in a peripheral hospital critical. If you don't do this on a regular basis, you may want, if you really want a central line, ask the surgeons to do it. TEE, you probably won't have this availability in a peripheral hospital, but it's sometimes more useful to look into fillings. And urinary catheter if you have a long procedure and you need to follow up urine output. So the goal actually is optimizing your oxygen delivery, optimizing your ventricle function, maintain euvolemia, and this is very, very important. Avoid increase of oxygen demand and tachycardia and contractility by having a good sedation for your child and deep anesthesia. Of course, it's a question of, very balanced question. Maintain synosism is by all means possible. Premedication, mentioned again before, too, is really important, and you do not want to have a crying child that becomes more cyanotic during induction. So midazolam is normally used. We use midazolam PO 0.5 milligrams per kilo and IV 0.1 to 0.2 milligrams per kilo, and I think that's the usual doses that are here. Children under 6 months normally do not receive premedication in our hospital, and sometimes Down children, they are so sweet and they sometimes don't need this either. So, oops, I need to go back one slide. When you induced anesthesia, you have to remind that if you have a right to left shunt, so your blood is actually not, your blood will be mixed and not going entirely through the lung, you will have a slower induction, and you really want to avoid, you have to be patient, this was mentioned before too, you have to be patient and not keep the sevoflurane for too long on high concentrations. IV induction can be faster in right to left shunts because the blood is actually immediately going to the arterial side. So, and in all others, it doesn't really impact. Propofol, we use propofol depending on in a stable child, but you have to keep in mind it makes vasodilatation, and you have to use small doses and incremental doses. And I think somebody who does pediatric anesthesia anyway, we do premature babies, we are used to use small incremental doses and not like on the adult side, you empty the syringe, you don't do that in pediatric anesthesia. Ketamine is our drug to go for. Combined with fentanyl very often. Etomidate also has no effect on myocardial contractility and is stable. Dexmedetomidine is more and more used specifically for sedation or in addition to fentanyl. At the beginning there was a big skepticism because it produces some bradycardia, but if you induce slowly, and actually we also use it quite a bit in the ICU for ventilated patients. Opioids, I already said, fentanyl is the most commonly used opioids, and remifentanil for short procedures. If you do a bronchoscopy, for example, or an EGD, you don't want to use too much fentanyl, and remifentanil really has a 3 to 5 minute window. Muscle relaxation as needed, and regional anesthesia can be extremely beneficial for postoperative pain management. Again, in the goal to decrease stress and to decrease complications from stressful situation. Airway management, whatever is needed for the procedure you're doing, everything is possible. Spontaneous ventilation with nasal cannula and capnometry, mask or LMA, or of course endotracheal tube. I just can only reinforce this. It's really important to have no air bubbles in your IV. Don't let anybody else set your IV up. Check it yourself. You, even in a left to right shunt, you can have a reversal of shunt or in mixed shunts, and you really don't want the devastating situation to have a stroke-like symptom in a child. Avoid hypothermia. Hypothermia also is increases morbidity and mortality. I'm not going to the endocarditis. This was already addressed before. Endocarditis prophylaxis has been significantly decreased. There are only a few indications, and it was addressed this morning in the previous lecture. So for the emergency and postoperative care, again, regional anesthesia can be very beneficial. Of course, you have to think, is the child, aspirin normally should not be a contraindication. It says my battery is running low here. Okay. Sorry, on my screen it says battery is running low. Neuromuscular blockade needs to be reversed, and in the pack you really need to make sure that you monitor oxygenation and ventilation. Also, it's important for these children to make sure that they take PO fluids as soon as possible so they can take their regular medication again. And for that, you also need PONV prophylaxis. And that should not be different from a normal child or a child with cardiac disease. I can't advance it here. So do we do this, do we do it in outside patient or in-house patient? Again, it depends, thank you. This depends on the situation. If the cardiac situation is, disease is stable, it was an uneventful anesthesia, the family needs to be on board, they shouldn't live too far away from the hospital in case they need to come back. Surgery should be minor, and the child should be able to resume oral fluids and take the regular medication. And always keep in mind, children with, at every stage, there are very few that are totally repaired. No, there are some that are totally repaired normal, but many of these children have limited reserve. And so the decision is. So basically, now trying to a little bit talk about the lesions that are there, and there are actually two big types also. And again, I said there are multiple classifications and they overlap, many of them overlap. So there's the biventricular repair, that's generally going without palliation. There are exceptions to that. And then there's the univentricular repair that normally has a 3-stage palliation. And these are, as mentioned before, are children that should really be done in a center where these kids are, where people are trained to take care of these kids. And I can only enforce every of these lesions has a large spectrum of severity and a large spectrum of variety of surgical repair. For the biventricular repair, these are just some lesions that you can see there. Usually, some of them, depending on the severity, need palliation with a pulmonary band, for example, or but most of them are a single repair. So now dividing these are just these show you what are the hemodynamic consequences of right to left shunt, left to right shunt, and your hemodynamic goals. And for somebody who's not doing this on an everyday, I feel there should be some place around, or a conversation or a book that you can read it before you do these kind of procedures. You have to have something in hand to understand. If somebody does not think about pulmonary resistance, systemic resistance, and how this is balanced on a daily basis, it is not in your head, and you will need to have something to help you to support this. So one example for the left to right shunt is the VSD, and you see here there are different types, and different types have different surgical repairs and different consequences, and some of the larger VSD can